Right there.
There you go.
My name is Kalenia Dempsey, and I work for the Utah Center of Rural Health at SUU. I'm a program coordinator. Actually new a couple weeks. It's my third week now, I think. I originally came from the Four Corners area. I manage a clinic and a mental health program. So I'm excited to be here and be part of this conference. So I'm going to ask Tyler and Danny to introduce themselves, their background, and why this topic is pertinent to you. We'll start with Tyler first.
She's closest to the camera. She has to speak first.
Yep.
It's all good. Tyler Goddard, I'm the health director for Points Health, which is owned and operated by Ivy in Trenton, Utah. Worked for the tribe for 11 years now. Tribe owns and operates several health clinics throughout Southwest Utah. Provide medical, behavioral health, dental, and other services to our communities, specifically focusing on the health and well-being of our tribal members, but then also serving the underserved communities that need services relevant to them as well. Why is this topic disparities is pertinent to my work and communities I serve. Kill the Zoom audience. The biggest thing is, Native American community, Native American people, fit into that whole concept of disparities and social inequity. There's a lot of disparities that impact our community members, as well as the other communities we do work with. So disparities is kind of the name of the game with the work we do.
Mm-hmm.
I am Danny Rodriguez, and I'm based out of Moab, Utah. And I work with Utah State University and with the Department of Health, and we're starting a community health worker core skills training, the same one that SUU is doing, and Lori's the instructor at SUU. Myself and a couple other people instruct with USU on our campuses, which are in Logan and Price, Moab, and then Montezuma Creek and Monument Valley. Yeah, community health workers, they're the frontline workers that hold the trust of the communities, have a natural friendship and camaraderie with their patients, usually. I mean, like always. And they've made a great difference in the pandemic response. And the communities I work with, so in Moab, there's a large Latin community. There's also just folks who are very widely spaced from health clinics and, don't hold health insurance. So there's a lot of disparities in access to health insurance. If you don't have a personal vehicle, there's no public transit, and in Moab, and I think in Price it's kind of tricky as well. And then there's also a large undocumented population in Moab, so there's a natural fear about legal repercussions with accessing healthcare, and especially with the pandemic. That was tricky with testing and with vaccines, because there was just a learning curve for public health and kind of how you can mitigate that fear of legal repercussions. I'll just give one example. So at the beginning of the pandemic, like with testing, it was available to anyone regardless of your immigration status. But public health workers were still saying, "Can I see your ID? Can your ID, because they needed to spell the name, right? And that was really the only reason. And so there was like this curve that's like learning to say, well, just write your name on a piece of paper. So just like small things like that, that actually the community health workers would understand this, but the large health clinics like didn't quite have that understanding. So had a huge impact on, you know, willingness to go get tested or to go get a vaccine. And then, yeah, we serve Navajo, RHAU. My counterpart, Ryan Benali, was hired to be a coordinator in San Juan County. He also works for Navajo Trust Fund, so I wish he was here to talk about his communities, but there's a solid cohort of like 14 people. Logan has a large refugee population, so we also, a lot of the communities we serve are refugee. So yeah, I can talk more about health disparities in another question. Maybe.
Thanks,
Yeah.
Thank you. Lori, can you hear us? Okay. Could you introduce yourself, a little bit about your background and why this topic is important to you? You have to. Okay.
Can you hear me okay?
Oh, we can hear you.
Okay. Aloha, everybody. Thank you for having me. I'm so excited to be here. So I am, well, first and foremost, with my collaboration with SUU, I'm excited to be an instructor for our community health worker certificate. I've had, I think I'm on my 4th. I'm trying to remember how many classes I've done now, but I think it's around 4. And I just finished one a few weeks ago. And we had a great turnout and interest for the community health worker certificate through SUU. We had, I believe, 30 graduate with their community health worker certificate, and they're so excited to get started in their communities with their final project ideas and just being there to volunteer and help in their communities however possible. So my foremost, that is really where my passion is and my heart is to encourage those who want to help in the community get their certificate, and then be able to just offer ideas and suggestions for community health workers all over the state of Utah. Since we are hiring quite a bit here in Utah for community health workers, there is a need. And so I think I'm really excited for the next 2 semesters working on this new classes for the certificate. I'm also with the Utah County Health Department. I'm in their COVID outreach team, which I love. Something I was doing before in their women's clinic, and then kind of due to the pandemic and the need of COVID outreach, I kind of stepped over and is helping with the vaccine events and just helping get the word out and education about the vaccine. And that's kind of where my passion has been right now, in collaborating with a lot of the different organizations in my community down in Provo, also collaborating with different coalitions, health coalitions in Salt Lake City.
Awesome, thank you, Lori. So we want to make this a conversation. If anyone has any questions, go ahead and raise your hand. You're more than welcome to ask our panelists questions if you have any. But I'll start. So tell us about those in your communities that have faced disparities during this time. What types, how it affected them.
Sure. Danny did a great job talking about, some of the, and we hit, we have a lot of the same things. We're in our Kanash clinic, Miller County. We have a large Hispanic population with similar issues of immigration. Language, of course, is an issue, trying to help connect people and help them understand. One of the things about healthcare, I think, what we do matters a lot, but how we do it matters, I think, even more. And making those small adjustments to, oh, I noticed that our Hispanic population, who start coming in for testing, is it because they just aren't getting exposed to COVID? Probably not. Why not? Why aren't they coming in? Or if they come in, it's only when they really have to. How can we change that? How do we do that a little bit differently, a little bit better with our tribal members and our tribal population? We saw, of course, and COVID hit our community members harder than other communities. So really looking at that, why? What is it about our tribal members, our Native American population, that increase their risk of severe illness and hospitalization? And of course, being a very small tribe, not a real wealthy tribe, not having a lot of resources, so we rely really heavily on our community partnerships and resources. Guess what? All those other agencies were just as taxed as we were. And so when we're reaching out, we're like, hey, public health, we need you. Hey, we're like, yeah, we'll get there. And so we had to do a lot more on our own. How do we do this? And our community health workers was a big part of that, our outreach team. That we had to bolster. We had to lift that up. And so that's where a lot of the disparities came to be. They weren't new. COVID just blew them up. And so they're like, wow, right in their face. Housing is an issue, food insecurity, socially disadvantaged populations now.
Yeah, I think with a lot of the communities that our community health workers serve, we saw food insecurity as one of the largest, and housing insecurity. I think one thing that was interesting too is at the beginning of the pandemic, it still is, but it was especially frightening for everyone because it was the unknown. And it's a communicable disease, and so I think a lot of the guidance that was coming down from like a high state level was kind of really scary because it was so based on like we need to separate, we need to be separate from each other and in our own homes. And for like a lot of the communities that I work with and that our community health workers work with, like to think of health without contact was like not really, like there's no health without contact. Like so much of well-being is built in the relationships and just communal aspects of the cultures folks are coming from. So I think there was at first some disparity with that, just in even like the language that would come from the higher level that was so focused on like social hygiene and like this is scary, that made it almost seem like there was judgment in having contact with people. I don't know, this might be a controversial thing to say, but I think that kind of pushed back a little bit, caused a little bit of pushback, and then as public health started to understand more and more deeper cultures and traditions and things like that, I think the disparities have improved. I'm not saying that's the cause, I just think it's contributed as well. Like there's a lot of our communities have no health without contact. So COVID's just like really disruptive. I'm gonna let Lori speak. This Lori's really
I think you hit it on the nail. I think rural and tribal communities often have multi-generations living in one household. And the concept of COVID, everyone separating, was a really hard concept to understand. And they say it takes a village to raise a family, and when you take that village away, yeah, I think every generation during this past couple of years have been pretty effective because down to our babies, to our grandparents. So yeah, I completely understand. Lori, do you have anything to add to that?
Sorry, the sound is a little off for me. It sounds a little muffled. So can you repeat the question?
Just talk about your communities and what disparities they've gone through and how.
Oh. Okay, great. Thank you. Can you hear me okay? I hear an echo, so it's hard. Okay. Just in the last year, one of the struggles has been one of the reasons why we started a vaccine event in the local communities. We actually worked with the local church to use their church building somewhere they felt more comfortable coming to get the vaccine was for our elderly Pacific Islanders. They had our wonderful seniors in the community. They had expressed a concern not wanting to drive down to the health department or drive down to somewhere they weren't familiar with. And so one of the things we thought of was having it in a community building that they knew well and that they were comfortable with. We were able to collaborate locally with the church building there and have a vaccine event. That was actually very successful because of just the different information that's going around about COVID and about the vaccine. They were giving some wrong information and incorrect education about the vaccine, which was actually quite frightening to hear the things that they've heard or they've read online. And so it was just about a little bit of having some education classes. They would come with their auntie or niece. That was a way to bring them into the class, and maybe it would be more of a cultural class, but then in the end, we would have a little health tip to try to help them understand what's happening with COVID and also help them understand the current events of happening with the vaccine. That was actually very successful. We had 3 vaccine events and we were able to, and people came, which we were so excited that they came and they wanted to have the vaccine. So for mostly what we were working on was just information that was about diabetes. We were really focusing on our seniors, giving them the correct information, guiding them to the correct links to look at, and just kind of helping them, giving them that resources and information so they can make their decision. That was one thing I had been working on for the last year.
I think that's huge, and it goes in with what Dan was saying as well. You were saying about the village and the contact. That messaging of everybody's got to be apart. You can't be together. You know, our multi-generational. We have childcare assistants and our providers are typically grandma, aunties, and what do we do when, oh wait, our elders are precious, which they are, and so we can't be around them because we'll get them sick. But I can't go to work if grandma doesn't watch my kid. Now what do? I have to stay home from work, I lose my job, and don't eat, and it just pounds. And so having that messaging of, okay, how do we make it safe for us to be together, to have contact? How do we improve those interactions? How do we improve the education about vaccines? How do we prevent somebody, help people to understand that no, you're not going to get deported if you go in to test for a vaccine? It is really improving that communication. And I think there are health workers and there's frontline people, the trusted people. And one of the messaging things that helped us was through our tribal leadership, tribal elders, making sure that, okay, this is somebody you trust. Here's the information. We make sure they have all the information, they help share it. And then I have the information, and, oh yeah, I came from Auntie so-and-so. I'm good. Oh, Auntie's getting a vaccine? Sign me up. But you can't have that if you don't have the right hands.
And I mean, those are all the questions that we began with, like after a few weeks into the pandemic. And so now that we're not over, but a couple of years, almost a couple of years have gone by, what innovations have you guys seen to improve addressing these disparities? Lori, you want
Go
to
back.
Yeah.
Can you repeat that one more time?
So what innovations have you seen now that we're about a year and a half into the pandemic? What improvements have you seen at every level of the system to address these disparities?
Definitely, I think our communication has, I think, really been so much better just in the last year. I feel like people know where to go for their resources. They know where to go for information. Maybe they don't always choose to go to those links or even, just the correct information. But I feel like the communication has been successful also on social media. I feel like communicating with the different, even more so, I think, in our different communities that I work with, I know that they reaching out to them and basically me just calling them or even texting them and asking them, have you heard of this? And they have. They've heard of an event. They've heard of the vaccine. They understand what's happening. A lot of people, everyone's sick of talking about it. Nobody really wants to talk about it anymore. But what I felt like was successful for my team, they know where to go. They know where to go to find the resource. They understand what's happening and they understand, the basic steps of either how to get a vaccine or understanding what's happening right now. And I think Utah has done a great job, even just within even with the local news. And I feel even with the local schools, I feel like information is getting out there. So that's number one. I think communication has really been key here. And I feel like it's doing its job.
I would say, built upon that too, the communication between the immediate public health response, like contact tracing and community health workers. Now we have contact tracers referring, not just asking about contact, but also about these other areas around social determinants of health, like, do you have food in your house? Like, are you going to be able to make a rent check? How's your emotional well-being? Contact tracers have been asking these questions and then triaging to community health workers like Lori at the local health departments and, at community-based organizations. And I think that is an invention, I guess, in that I don't know if it existed before this, because I worked in communicable disease epidemiology before this, and we didn't have that triage or, like STD calls, contact tracing to community health workers. But we're seeing with COVID the amazing impact that it's having, also in like breaking down stigma, so we can see how it could translate to other like ongoing health.
You touched exactly on what I was thinking, because I have been a contact tracer for the state, and so before taking on my previous role now in primary care for health as a workforce coordinator, but as a bilingual contact tracer, I saw that Utah was really great at reaching out to a lot of community members and making those calls. Like we had to do the Medicaid calls, the outreach calls, also the Utah Response, like working on like getting all the physicians, or if you weren't physicians, if you were at MA, you were able to you were able to administer the vaccine, getting those clinics and all that. It just showed like that whole coalition aspect of it. Yeah, and that to me was really fantastic. And being a bilingual, speaker and being able to talk to the Spanish community, a lot of them, they felt that we touched on it too. I have to pay for this, and I'm like, no, you don't have to pay for it. Or it was just educating them on all those things. Or one of the things that I found that, it had to be reciprocal because of being a health advocate was like, if I'm going to give you information about me, what can you do for me? So something that we have as, community health workers in that arena was, our background was, well, we can do where that, you need to be isolated. So that they can't really fire you, so it's like educating them. Oh, I can get this letter. Oh, but I don't have email, but you can send it to my grandson, or so then it was from that resource, then the exchange dialogue. changed completely. And I thought that was very transformational. And then one woman called and that I called and she was just crying and so happy that like, you know, the Utah Health Department was calling her. She just knew that it was a health department. She didn't know what if it was local or not, because obviously the local health department was dealing with like most of the school cases, but the state was dealing more with like the personal adult cases. And so she was just so happy and just like, I don't think anybody would call me. I've been isolated for so many days now, and my family, I need to talk to them. And so just like talking to her, letting and understanding her and connecting her to all the resources that she needs be the biggest difference. So you're right, like it does really make a big impact. And just little did you know that you're talking to people from all across Utah, but we do have a large community that is not only Hispanic, but even with our indigenous population. Like once we found out that they identified with a tribal affiliation, as contact tracers, we couldn't terminate the call with them. We had to continue the call with them. And then we would just let the leadership know this individual is, affiliated, and so then they would have somebody else to trace with them. But at the same time, a lot of contact tracers are finding information they receive, and they're like, oh no, we'll have somebody from tribal, that deals with that, will call you back. And then it was like, no, you can't cancel that. And so even within like structural, there's a lot of learning curves. And it was really interesting to see how all developing and formed the our decisions now.
I love how like in public health and, primary care, probably mental health, the pandemic has made us like very interested in this like translational science model where we improve and we like learn and we improve and we learn. So like I feel like it's made all of us more collaborative. And personally, yeah, like I feel like I could call people on the contact tracing team working with the community health workers, like they would work with us, like not violating it whatever. but yeah.
A lot more, I like that, collaborative, and I think being willing to try new things, whereas maybe before, no, this is how it's done, and this is how we have to do it. We had a lot of lines drawn, and I think we started blurring some of those, and then just totally erasing and redrawing, and let's just try something new because what we're doing is not working, or it's not going to work for this situation. So it's been, a couple of things. First, for us, innovations. One of the big ones, of course, telehealth and the communications networks. Improved. Fortunately, we had already started down that road before COVID, and then we were able to just fully launch and ready. But then we found, some of our communities and community members aren't connected. They don't have the devices. They don't have the internet to their home, even to their community. Our one clinic in Kanash, that community's been, it's kind of a dead zone for most cell phones. There's one internet provider that's charging crazy amounts. Nobody in that community is able to afford it. And so, we're able to work collaboratively to say, hey, you're running fiber right up the road 5 miles away. It's going to cost to get it to this little community here. And never thought about that. That collaboration, that thing that we wouldn't have thought to ask if we weren't kind of forced to. That was one of them. Another one that has been huge has been we started just to take care of our elders because we knew what they would be. They were pretty isolated. Was just an elder care package that we would set up every month. And of course, that forced us to, hey, we need to make sure that our list of who our elders are, where they're living, how to contact them is up to date. And so we spent time doing that and working on that. And hey, now we're going to call and check in. And a couple of them said, you know what, my family's taking great care of me. Please stop bugging me. Like, okay, not a problem. Except we're probably going to check in with you every so often, and every one of them, have said, thank you. And then that rolled into Thanksgiving's coming up. Would it be okay if we deliver a pie and some whipped cream to you for Thanksgiving? Sure. And while we're here, let's ask all those questions like, so are your pantry, is your pantry stocked? How you doing with other things? How's the rest of your family? And it just, kind of rolled into just something that now our workers love, even though it's more work. Like, I know every elder in the tribe. I know what they like, what they don't like, who they're connected to, and it just expands. And of course now, guess what? We're trusted by our workers, our social services folks are known by the elders. And so when they contact somebody in the family says, do you know them? Are they okay? They're good. And they get in the door. They're able to do the work they need to do, whether that's medical thing. And the other innovation is just helping people understand communicable disease, whether it's COVID, whether it's something else. It's not a naughty thing to have it. Because I think that was one of the big things we saw was, oh, you have COVID, you are ostrich, yeah, you're dirty. No. You have, they're just like with the flu, you cut a bug. What do we do? Let's help take care of it. But it was a huge taboo, bad.
I want to pitch something that I think Lori's involved in too. And sorry.
Yeah, you're right.
So what I thought was really amazing too was that kind of all these community health workers across the state were coming together for coalition meetings on Tuesday nights, which were run by, I think, Ouch, Lori might know more. But yeah, you'd have like the state epidemiologists in a room with all these community health workers from across the state, and a chance for them to be like asking questions to the state epidemiologists. So I don't know if that's like an innovation, but I just think the levels of separation, which kind of go back to what you're saying between not just like practitioner, but also like high up public health people and the community, really like got either removed or condensed through like creative ways, like, telehealth essentially is what that was. So
Lori, do you have anything to add?
I love what I'm hearing here. This is awesome. I love how you're getting into communities with pie and whipped cream. That's awesome. I think food does a wonderful thing to kind of bring people together and build that trust. I understand that, building that trust with the community so that we can also talk about other things and especially important things like health. I agree. I love our community health worker section. I think before, I remember a few years ago when we were just maybe 15 would show up or even just 10. And now I think the last meeting we had seemed over 50 people, I think. So again, I just have to give a plug to the communication. I think has just been done so well. And I think we're across the board in the state of Utah, community health workers we're communicating better. I feel like I have more meetings than ever now, but I think it's great because we're sharing our information that we have, sharing our resources that we might not know that we can share with the families that we're working with, and then they can share with their families. And then it's a wonderful domino effect. So I'm loving it. I'm just happy to be here and listen to, it's just great to listen and hear where we're going to be in the next few years. I think we can only go up, right? I think it's going to be a positive. I'm hoping. I think it's going to be a positive experience.
Awesome. I wanted to bounce off of the collaboration. One thing that popped in my mind is we would say integrated healthcare, and coming from Utah Navajo Health System, they would advertise integrative healthcare, but I guess COVID finally made that what it was, because we did have a behavioral health clinic and a medical clinic. But like you mentioned, Danny, they didn't necessarily click all the time, but COVID kind of forced that. And a lot of COVID patients explained that they had this like brain fog or had depression and anxiety after being diagnosed with COVID. And so just seeing that collaboration and being that having to force both the social service side and the behavioral health services in conjunction with the medical side, I think that that was a huge learning curve. How do you guys feel about that? What was your experience? Medical professionals.
Definitely not the medical professional. No, in a lot of ways it has, and then we blurred some of those lines or helped us to break through some of those barriers or walls that were built up. There's still definitely room to grow, lots of areas that we still need to work on. But yes, those collaborations I think have started to increase, and my hope, of course, is that the momentum that we're getting or have gotten so far doesn't stop, and we're like, okay, great. Now we're going to get the kiddos vaccinated. We're all good. COVID's a thing of the past, and now we can go back to business as usual. I hope not. There are some things I'd love to go back to business as usual, but that's not one of them. The integration, the increased community health workforce, and our administration and others being able to see that as the valuable asset that it is. And for our providers to see, and just everybody that has worked together, we can say, it's a team, it's the village, we need to, and how can I share this information? Not, oh, I can't because medical world, HIPAA seems to be the favorite thing to throw out. Nope, can't share that because of HIPAA. Actually, that's, I love our compliance guy because his whole thing is actually HIPAA is created for to help you legally share information. It's not to prevent. So we need to look at how do we do it in the right ways.
The community health workers training that Lori and I will instruct for talks about confidentiality and, kind of HIPAA rights. So you're training those folks who are interfacing with their community, and often like people come to them with mental health challenges or something very private and personal. And I think it also provides a level of trust. At least I've seen like with a couple communities where, the conversation used to be around, well, like, you don't want other people in the community to know that we're struggling. So like, I don't know, how do we address like mental health stigma when you don't want anyone to know? And now it's like more like, well, we have people in the community that we come to anyways, that we trust, that are also like really understand how to navigate this confidentiality aspect. And I don't think that's solely because of the training, but I think it's a great aspect of it. I think also just like the students having conversations with their communities around like topics that tend to get stigmatized, like mental health, and opening up the open dialogue so it becomes more normal to talk about distress, like which everyone encounters. So I don't know if that's kind of thing.
So how, just bouncing off of what Lori mentioned, she seems really optimistic. We're gonna just go up from here. So how do you see the landscape post-pandemic once we get there?
I really hope we continue to contract and work with community health workers, because I think, sorry, I just jumped right in there. I cut someone off. I think like, you know, at times there's sometimes an expectation that community health workers, well, they're doing their community work already. They want to do it. They care about their communities and like, but then not the conversation about pay. And so it's like, you know, I really hope post-pandemic, this isn't just like COVID money that's helping integrate community health workers into the system, but that, you know, maybe their time would be billable to Medicaid or something like that. So we could really integrate them into the whole model, the medical model. And I know that that's being worked on like at a legislative level and, you know, with certain leaders. So, yeah, I'm optimistic too because of that.
Very hopeful that things will continue along these lines. I think we're seeing value in collaborations, the sharing, and taking care of it. In a lot of ways, I think the people that we're helping hopefully will voice, we like this way.
Mhm.
Their voice can be heard. Because we see it over and over again, hear it over and over again. Oh, you know, you saved me. Health worker or a social worker dropping off a pie, you saved me. You know, get that, but we've had workers come back and just in tears and like, you can't believe what just happened. Delivered a pie. And they're like, yeah, the conversation that I had over that pie was amazing. And they got information, they were able to talk to a provider, a mental health person, connect them in, and then the person's like, that visit was exactly what I needed. Had nothing to do with pie. But it was that increased, the increased resources. I hope, again, they don't go away just because we got trillions of dollars floating around everywhere. And so, yep, let's spend it on everything. Let's spend it in the right things, and let's reimburse and pay people what they need to be paid to do the hard work they're doing.
Mhm. Lori, do you have anything to add to that?
Not really. I just enjoying listening and already feeling just kind of the collaboration with everybody, especially within our community health workers section. I've just had such good experiences the last few months in our meetings. I feel like we have broken barriers, and I'm really impressed with what everyone has done in their own communities. And it's so nice to hear. It's almost a treat for me to be here and just listen to how you all are breaking through the communities that are in need and breaking through those barriers. It's encouraging for me to help in other communities, Pacific Islander communities throughout Utah County. So thank you.
So I also wanted to just bounce off of some of the innovations. So the Utah Center of Rural Health is working with the Office of Primary Care and Rural Health and establishing programs around health equity. And Southern Utah University, or SUU, became established Project Echo Hub this past week. And so if you all know what Project Echo is, it's a system where the model where we try to prevent the patients from traveling, and that it's like a peer-to-peer, professional to professional education virtually. And so we're excited to get that project started and hopefully address some of these disparities and make it sustainable so that we don't have so many disparities. And with those series, our Utah Center for Rural Health office is pretty excited to receive any feedback from community health workers, people on the ground who need that virtual collaboration and training, and so that we be able to compile topics that will hopefully sustain these types of service post-pandemic. Yeah, that's super exciting. But yeah, those are really all the questions that I had. Does anyone in the audience have a question?
Well, great job with your phenomenal work during the pandemic. And wonderful to hear how you've been linking resources. I'm just personally interested, to what extent do you use a resource like 211? Is that applicable to rural settings or to tribal settings? Or I'm just wondering if that is, are you familiar with 211? Yeah. And is that helpful or not? And how can we improve a system like that for our state?
Yeah. I'll speak kind of from a Moab lens first. Like, I don't think it does get called as much because the community is so small, like in that area, that, you know, the community health worker will just figure it out.
Yeah.
And like,
They are the 211 in the.
yeah. Yeah.
I would say, tying in our community health workers into 211. In a lot of our really rural areas, there just aren't the resources. Okay, yeah, mental health, that's who I call.
Yeah, there's just like one person.
Yeah.
Yeah.
But, we've used it. Most of our clinics are right along I-15 or in Cedar City and St. George. So we have some bigger communities where it is useful and helpful. And we need to continue to expand and say, oh, and there's this new thing, and make sure it's updated. But I find it useful, but yeah, rural areas, it's hard to have a resource list when there's a resource.
Yeah, and I feel like with rural communities, 211 would mainly list national services.
Okay, yeah.
And so that really doesn't correlate with the local aspect. And I feel like in rural communities, there's grants always cycling through, and it might not be even a long-term grant. It's just, and so there's a new service for this short amount of time, and so I guess it's not time effective to like wait for 201 to post it, and then by then the grant cycle is probably over. So there's a lot. I mean, it's a very useful tool, but it's not very friendly, user friendly for rural.
It works better for something.
Yeah, sure.
Pretty good with the larger government agencies. Almost always spot on.
I feel like for like the Moab Valley Multicultural Center, it was better just to get the contract where they could access the pot of money. So they could like order groceries to go somewhere rather than like navigate these different, or like help them just with the rent payment. And just be able to go there and do it. That was really helpful. I don't know if it's quite like a pot of money. I don't know if that was the right term to use, but like to have access to use their good independent judgment of which clients need what kind of help, and kind of navigate that on a one-to-one.
Question.
I have a question. Is there, I know community health workers, there's every state is a little bit unique. Is there a certain state you guys hope to like mirror off of? In terms of
Those.
I'm gonna say Navajo Nation has community health representatives who've been doing the work forever. So when I think of like a state and like who's been doing this for so long, I actually think about them, and like they have like just a little piece maybe with integrating with UNHS and health clinics, but like, I don't know if you're, yeah.
So I guess one kind of perspective that I have with rural communities is that a rural community is kinship, and that's what Utah Navajo Health System kind of bases their service on, is that, and I guess it was mentioned in the video this morning that we try to do more with less, and the whole collaboration. We had case managers from the behavioral health clinic serve as contact tracers, and then we had people in the maintenance department and administration who just took over with care packages. And so something that was not necessarily in their scope of work just jumped ship and went out into those, to the dirt roads and started delivering those care packages. And so I think that there wasn't necessarily a model, but it was just the concept of kinship and saying, let me just jump in and help my neighbor, essentially.
It's Indian Health Services for years has done community health rep, CHR program, Alaska, and these kind of things like that, turn it into a aid program that's really good. And so that's kind of what we're really looking at. Okay, what are the areas that have taken this and really done a great job with it? And it's, again, Indian Health Services. But those are things that cannot be get paid for or reimbursed through insurance. And so pulling them into the community health worker and hopefully initiatives that legislation and things to where that's a billable service, and it's a critical service in addressing the social determinants of health and healthcare overall, because our community health workers, our CHRs are going out and helping with testing and
Well, we're getting close to our end time, but I wanted to thank the panelists for joining us. Thank you, Lori, for calling in, and thank you all for coming and just being a part of the conversation. And I know that Disparities is ongoing, and so I encourage everyone to network after this and bounce some ideas off of each other, because we do come from really unique communities, and I feel like, yeah, I'm so appreciative of each role in rural communities. And so, yeah, thank you so much, and travel home safely after this.
Thank you. Bye.
Don't forget, at the end of your program,
We do
there's
have one
a-
more session after this,
Okay.
and then Barbara.
okay, the last page of your program has a QR code. So at the end of the conference, be sure to scan that for something.